So mild autonomous cortisol secretion, arrival of an entity. This is the assignment given to me. We have familiarity with subclinical Cushing syndrome, and I'm sure most of us do know this entity. Subclinical Cushing syndrome was recognized almost 2 decades back, and perhaps that was given recognition when they found that the association of subclinical Cushing in fact leads to clinical entity, and therefore it is misnomer to call it subclinical Cushing syndrome. So better word would be mild autonomous cortisol secretion, and that is the entity now being recognized. Its recognition actually started with identification of adrenal incidentaloma. Adrenal incidentaloma is discovering of adrenal tumor in an adult undergoing cross-sectional imaging. And with the advent of ultrasound as well as CT scan and MRI, the adrenal tumors are being recognized very frequently. Now, these adrenal masses, this could be benign or malignant, and it has been seen that only 12% could be malignant, but mostly benign. And 15% are functional, so mostly they are non-functional. So adrenal incidentaloma, that poses a clinical challenge to all the endocrinologists, that they have to investigate whether it is benign or malignant, because though a small proportion is malignant, but yet we have to identify that it is not malignant, and very small fraction is functional, so we have to identify that it is functional and adrenal incidentaloma. Uh, Mainly it is either aldosterone producing or glucocorticoid producing adrenal incidentaloma, so around 15% are functional. With the recognition of the entity of subclinical Cushing syndrome, as I told, and this was mainly identified with adrenal incidentaloma, that these are functioning adrenal tumors which are producing little excess of glucocorticoids. But actually, that is not producing a uh, feature of Cushing syndrome. So, by definition, MAX is MAX is the biochemical evidence of abnormal cortisol secretion in patients with adrenal cortical adenoma, but without the classical external manifestation of overt Cushing syndrome as central muscle weakness or adipose tissue redistribution or skin fragility. So it is misnomer to call it subclinical Cushing syndrome, as there are some clinical clue of mild autonomous cortisol secretion in incidentalomas. If you call it early Cushing syndrome, that would also be misnomer, because when the natural history of MAX is tracked down, what has been observed that it doesn't progress to overt Cushing syndrome. So very small fraction actually progresses to overt clinical Cushing syndrome. Therefore, we cannot call it early Cushing syndrome. And not only that, some of the cases actually recover completely, means the functional status regresses, though it doesn't. It is not accompanied by regression of the mass, but there is a regression of the functional status. So we cannot call it early Cushing syndrome also, and therefore it is very right to say that it is arrival of new entity or recognition of a new clinical entity. This is a very good cartoon. Actually, this was published in Clinical Pharmacology recently, 2019, by Delivanis. That in case of adrenal incidentaloma, the possibilities are that it is non-functional in majority. However, it could be functional also. It is non-functional, but it has been associated with increased prevalence of hypertension, diabetes, obesity, dyslipidemia, osteoporosis. So is it related to the non-functioning adrenal tumors, or these common clinical comorbidities are actually very common in general population? But it has been seen in some of these studies that those who had non-functioning adrenal tumor actually had a higher prevalence of hypertension, diabetes, obesity, dyslipidemia, and osteoporosis though their cortisol production was normal. Then subsequently, they observed that there is an excess of cortisol, and that was named as mild autonomous cortisol secretion. And there was a more chance of association of hypertension, diabetes, obesity, dyslipidemia, osteoporosis, and frailty. When the glucocorticoid production is further high, that leads to clinical Cushing syndrome. So overall, this is the current information available. In fact, this is an old paper of 2004, but overall prevalence of MACs recognized in these papers were around almost 50%. 48% of patients with incidentally discovered adrenal tumors had mild autonomous cortisol secretion. And the chances of having MACs was more if the adrenal tumor was more than 2.4 centimeter. But the overall prevalence of MACs is around 2% in adult population. When you talk about the prevalence in people who had adrenal incidentuloma, obviously you have a high prevalence of MACs, but in general population it is around 2%. And common presentation was again hypertension, obesity, and type 2 diabetes. Less than 1% progress to overt CS. Therefore, it is not right to say that this is early Cushing syndrome. So they might remain static throughout, or though the studies have shown over 4 years the overall natural history of the condition, over 4 years they didn't progress to frank Cushing syndrome. And many more sporadic papers have also suggested that they remain static for the longer period of follow-up. And this unique chronic entity, this cannot be called as early Cushing syndrome. So that was the suggestion long ago in 2004 in this endocrine review paper. The diagnosis of MACs had been debated many times regarding the cutoffs and the cutoff value of the cortisol and the metabolites of cortisol. But this is one what I got from the literature, and I think many endocrine society guidelines have also have given the same consensus that 1 milligram dexamethasone suppression test, the cortisol excess, no cortisol excess if it is 1.8 microgram, as we all know that this is the cutoff for making diagnosis of hypercortisolism. The value between 1.9 to 5 microgram is a possibility of max, and the value more than 5 actually leads to overt Cushing. The urinary free cortisol remains normal even in max, but in frank Cushing it is elevated, and therefore that is used as a screening for Cushing syndrome, but that cannot be used as a screening tool for max. Late night salivary cortisol might be elevated in some of the cases, but usually it is normal, so that can also not be taken as a diagnostic tool for making diagnosis of max. ACTH may be slightly elevated in max, but usually it is normal. And in overt Cushing, obviously it is high. So suppressed ACTH may indicate, but one should look for Cushing syndrome if it is suppressed ACTH. DHAS is usually normal, or it may be undetectable in max and usually undetectable in Cushing also. So the diagnosis of max is based on the 1 milligram dexamethasone suppression test, and the value between 1.8 to 5 favors the diagnosis, but underline it, it favors the diagnosis. We are still in dilemma of confirming the diagnosis of max. And the value more than 5 actually supports diagnosis of overt Cushing, and there might be some subtle features of Cushing, so it could be a case of Cushing syndrome and not the max. So still we have a dilemma, and we should debate on how to make a diagnosis of max. The clinical consequences have been recognized that those who have adrenal mass non-functioning with the cortisol normal or dexamethasone suppression test normal, they still have high chance of hypertension, and similarly they may have obesity, or they have dyslipidemia and diabetes. But if they have MAX, these underlying comorbidities have higher prevalence than those who have only the mass. And if you compare with the normal population, definitely these two comorbidities or metabolic sequelae are more if there is an adrenal tumor or incidentaloma. And therefore, people started talking about the some treatment plan for MAX. And but again, as I said, that there are still dilemma about the final diagnosis. I will come to that part also, how to overcome. And with time, perhaps you would be wiser enough to make the diagnosis of MAX uh, with definitive diagnosis. But still, the treatment guidelines have been suggested that patients with established mild autonomous cortisol secretion look for the comorbidities like hypertension, hyperglycemia, obesity, dyslipidemia, and low bone mass. If it is present, they say that go for a definitive treatment of adrenal tumor or adrenal adenoma. Also consider the age of the patient. Younger the patient, more is the chance of having these comorbidities with time, and therefore they should also be considered for some kind of treatment. If tumor size is more, as I said in the beginning, if it is more than 2.4 centimeter, if it is a bilateral mass with predominant nodule on one side and high degree of cortisol production, one should also think of uh, providing some treatment. Potentially emerging biomarkers, actually, these are the newer technologies or newer developments that might help us to identify who would be benefited by definitive therapy for MAX. And that is an area of discovery or area of study and research. The management basically is adrenalectomy if it is a large mass and you have proved that there is a MAX. Post dexamethasone suppression cortisol more than 5, that is favoring diagnosis of overt Cushing, but also that is MAX. So if that is there, surgery is indicated. If there are comorbidities, which I enumerated in the beginning, the severe comorbidities, one should consider adrenalectomy or the removal of nodule on that side. Younger patients, the size more than 2.4 centimeter. In case of bilateral nodules, the dominant nodule can be subjected to adrenalectomy on the side where is the dominant nodule. Usually, it has been seen that 50% chance of post-op insufficiency in patients who are undergoing adrenalectomy or incidentalomectomy. If incidentaloma is removed and it is functional, there is a chance that patient will undergo adrenal insufficiency. If it is non-functioning, the chance of developing insufficiency is very minimal. So presence of adrenal post-op insufficiency suggests that it was a functioning nodule and the surgery had been rightly done in that particular individual. However, this is further debated. Many patients have, after surgery, have reported that they improved, and many of the patients actually have reported that there had not been any improvement overall in their quality of life, and therefore this was also debated that surgery should be done or not. But if there is a post-op insufficiency, perhaps the surgery was indicated. But then this is a retrospective observation and uh, and justification for surgery done in that particular case. So low post-operative morning cortisol, less than 10 micrograms, suspect that it is adrenal insufficiency and surgery has been rightly educated. Development of glucocorticoid withdrawal symptoms after adrenalectomy. If the patient develops low fever, low quality fever, quality of life, or weakness, lethargy, think of adrenal insufficiency, and that also supports that there is a hypoadrenalism or adrenal insufficiency. But interesting thing that recovery of hypothalamo-pituitary adrenal axis is shortened in patients with MAX when compared with patients with overt Cushing's syndrome undergoing surgery. So if the surgery is done in these individuals, the recovery of the axis is faster because the other contralateral adrenal is not that much suppressed, and recovery is faster in these individuals. So that should be also noted when they are replaced with steroid following surgery for adrenalectomy. It has been seen that following adrenalectomy, many of them do not improve, like the hypertension has not improved significantly, though the more than 60% improvement, but still the hypertension has not improved completely. Diabetes has also not improved. Obesity has not come down, and the uh, dyslipidemia has not improved. It means that only removal of the adrenal is not sufficient to lead to improvement, or perhaps it had been too long. The patient has spent with hypercortisolemia, and therefore the effect of hypercortisolemia is not reverting back, even if cortisol level has been brought to normal. So that is the challenge, and therefore we still raise doubt on the selection of patients for Cushing's for adrenal surgery in case of MAX. The other management approach could be pharmacotherapy. But the problem with the pharmacotherapy that we do not have evidence comparing the adrenalectomy with the medical therapy. And it is very costly, and it has to be given lifelong. The safety of these agents are also questionable. So we cannot depend on pharmacotherapy for treatment of MAX. However, the two drugs, mainly the metarapone and mifepristone, have been approved. Metarapone approved in by FDA, and mifepristone in US, in European countries only, for treatment of these cases. But again, as I said, that we do not have enough evidence to support that pharmacotherapy would be a good choice, and it should be preferred over adrenalectomy. We should remember the some of the problems, like metarapone corrects the abnormal circadian rhythm of cortisol secretion, which is always there with MAX. So that is one advantage with metarapone therapy. Ketoconazole, we all know, we have used the problem of hepatotoxicity and hypogonadism, so it is not a good choice. Mifepristone uh, also improves the insulin resistance. So those who have hyperglycemia or diabetes, they would be benefited by mifepristone. But remember some of the major side effects: arthralgia, nausea, headache. These are the common, simple. But the serious concern would be decreased blood potassium and endometrial thickening, and that should always be remembered. But again, as I said, that there is a lack of evidence, and the cost and benefit have not been proven. Therefore, it may not be a good choice. However, those who are more worried for their adrenal mass and the surgery is not actually indicated, we can buy time for them to give some of these medical therapy. So somewhere something incredible is waiting to be known, and this is what I'm going to add to it. Emerging diagnostic biomarkers. Why do we need emerging diagnostic biomarkers? Because there is uncertainty of the diagnosis. As I said in the beginning, the level between 1.8 to 5, but sometimes even above 5. Now 1.5, 1.8 to 5, we are calling it max, but it may come to normal also. So we really do not know if they have a significant problem because of cortisol post DST of 2.5 microgram. It means that we need to have some additional test to demonstrate that there had been enough of impact of the hypercortisolemia, and therefore the biomarker should also be taken into consideration for making diagnosis of MAX. So there is uncertainty of the diagnosis, lack of clarity in surgical benefits, as I discussed. Could we take help of these biomarkers in deciding who would be benefited best, and then we validate these tests so that we find out the correct answer, who would be most suitable candidate for adrenalectomy if they have MAX. Identification of cardiovascular risk, high risk group, and intensification of treatment of comorbidities, even if they do not qualify to undergo adrenalectomy. If they have MAX with some metabolic consequences or sequelae, then we need to intensify the comorbid conditions, because the presence of hypercortisolism will add to complications of comorbidities like hypertension. The cardiac risk will be more. If they have diabetes, again, the cardiac risk will be more. If they have a bone abnormality, osteopenia, that will become worse with hypercortisolism. Or if they have frailty, that is also enhanced due to hypercortisolism. So some of the biomarkers we all know is a proteomics. So biomarkers is steroid metabolites, mainly in serum and urine. And we can also rely on body composition markers, bone turnover markers. Serum steroid metabolites mainly are the multi-steroid profiling, which is done by LCMS-MS. This is the most reliable technique for measurements of steroid and metabolites. So by LCMS-MS, we can identify level of DHEA and androstenedione in men and women, and testosterone in women, which are low, and the cortisol metabolites which are in excess. Why does it occur? If there is a autonomous functioning nodule acetate is suppressed, and this will lead to low level of adrenal androgens, but same time the cortisol levels are increased. And therefore, this differential metabolism of adrenal gland can only be assessed by LCMS-MS. So this is very good tool to know that there is a some kind of differential alteration in adrenal hormone, adrenal cortical function. So 24-hour unit multi-steroid profiling by LCMS, it offers a more accurate estimation, as we all understand, of steroid production. It removes the confounders of binding proteins, and we measure the free metabolites. It is not affected by the circadian rhythm of steroid secretion, and this is quite dependable. But this cartoon, this chart is too big just to impress on you that there are so many metabolites in serum and in urine. The serum metabolites of cortisone and urinary metabolites of cortisone and the androgens. So there's a huge list, but all these profiling is possible with the help of LCMS, uh, LCMS-MS, or the urinary profiling is possible with GCMS, that is a gas chromatography mass spectroscopy. So with the help of these, we can do it, but it is a big challenge to standardize LCMS, MS, and GCMS and MS. And with time only, we will be wiser to validate these tests for making diagnosis, but we need more time before we really depend on these tests. Bone turnover markers, mainly the bone formation markers and bone resorption markers. I am not going to that much detail. Osteocalcin and procollagen 1, NP, and CTX and deoxypyridinoline. These can also be measured, and if the bone resorption markers are increased, formation markers are decreased, that suggests that there is a hypercortisolemia. One interesting bone marker is chloroastin. I'm sure you might remember this. It is a negative regulator of bone formation, and it is a product of SOST gene, which is down regulated by SOS gene is actually up regulated by the cortisol. So if there is a cortisol excess, SOS gene is upregulated, there will be more sclerostin and there will be low bone turnover because bone formation is reduced. But in people, in patients with, and this is one of the explanation why there is a increased osteoporosis in glucocorticoid induced osteoporosis. But in patients on cortisol replacement or cortisol excess, the sclerostin level was found to be low, which is a product of osteocytes, and osteocyte autophagy is increased in presence of excess of glucocorticoids. So sclerostin level is low, and that is not actually showing that there is a good bone formation, but it is reflecting that there is a low osteocyte function, and therefore bone quality is deteriorating. So low sclerostin, high bone resorption markers are suggesting that there is a excess of glucocorticoid, and these max patients actually would require some kind of intervention. The BMI or the fat distribution in the body is also a very good marker. Uh, those who have abnormal fat distribution with excess of glucocorticoids might be benefited by adenylectomy. In fact, they have also demonstrated that following adenylectomy, the insulin resistance improved and the adiponectin level improved, and perhaps that could be a good uh, marker for deciding the adenylectomy in patients with MACs. Uh, I'm not covering that part that we all know, but there had been attempt to associate the max with the fat distribution in the body, and there are papers to demonstrate that adrenalectomy has actually improved the fat distribution in the individuals. So I'd like to summarize here that mild cortisol secretion is prevalent condition as associated with increased prevalence of cardiovascular risk factors, cardiovascular events, and mortality. So in those who have high chance of unexplained cardiovascular risk, one should look for, particularly if there is an adrenal incidentoloma. Current challenges include diagnosis of clinically relevant MACs, especially in asymptomatic patients, when adultomy could potentially prevent development of metabolic abnormalities, and the lack of head-to-head comparative study between adultomy and intensive medical therapy of comorbidities actually are not there. But if that would be available, we would be having confidence in treating these patients. Current standard of care uh, diagnostic tests demonstrate suboptimal diagnostic accuracy, especially in relation to assessment of the end organ cortisol exposure. Several novel non-invasive biomarkers have shown initial promising results, such as urine and serum steroid profiling, sclerostin, body composition measurements, and bone uh, mineral density and bone histomorphometry. So with this, I end my talk here. I'm sure all of us might have been sensitized with this new challenge, which is almost parallel to the nightmares of diagnosing Cushing syndrome. And as we are discussing, and 100 years of Liddell's discovering diagnosis of Cushing, still we are finding our way go ahead for making definitive diagnosis related to adrenal cortical diseases. Thank you very much.
Well, thank you